Hello, my name is Daniyal Abbas, and I'm an internal medicine resident at East Carolina University in Greenville, North Carolina. I would like to thank Dr. Ali and the team at the IBD Journal Club to provide me this opportunity to present the article titled A Microsimulation Model to Determine the Cost Effectiveness of Treat to Target Strategies for Crohn's Disease. This article was published in April 2021 in the American Journal of Gastroenterology. The current recommendations for treat-to-target monitoring in Crohn's disease suggest that patients should be monitored exclusively by lower endoscopy 6 to 9 months after treatment initiation or intensification to guide adjustments until endoscopic remission is achieved. This strategy of monitoring remission in Crohn's disease is not without risks or costs, and consideration must be given as to whether monitoring exclusively with endoscopy represents the most ideal strategy for treat-to-target monitoring in Crohn's disease. The CALM trial was the first clinical trial to demonstrate that biomarker-based monitoring was cost-effective in patients with Crohn's disease. An analysis is needed in Crohn's disease to understand if the currently recommended endoscopy-based treat-to-target approach is warranted, or if providers can progressively shift towards biomarker-based monitoring to optimize outcomes while minimizing risk. In this study, an individual-based straight transition microsimulation model was built to simulate treat-to-target monitoring for 100,000 Crohn's disease patients being monitored with colonoscopy versus 100,000 Crohn's disease patients being monitored with a combination of symptoms and biomarkers, with the primary treatment goal of endoscopic remission. A 6-month cycle length was chosen for the treat-to-target monitoring interval of Crohn's disease patients over a 5-year horizon. Published literature was used to help model probabilities of treatment response, disease relapse, disease progression, need for surgery or repeat resection, risk of hospitalization, risk of complications from procedures or surgical interventions, and diagnostic performance of fecal calprotectin. Multiple patient-related factors having the potential to modify downstream probabilities were included as key model inputs. Infliximab was chosen as a first-line biologic therapy. The effectiveness was measured using quality-adjusted life years. A willingness to pay threshold of $100,000 per quality-adjusted life year was used as a benchmark, and incremental cost-effective ratios under this benchmark were considered effective. The endoscopy-based monitoring group spent more time in the remission state, fewer proportion of patients required surgery, and there were fewer total hospitalizations. From the 18 months period to a 5-year horizon, the endoscopy-based monitoring strategy dominated cost effectiveness. For the 1-year monitoring and observation period, the biomarker-based monitoring strategy dominated cost effectiveness. Once in endoscopic remission, the biomarker-based monitoring strategy was more cost-effective throughout the biologic sequencing algorithm over a 5-year horizon. The endoscopy-based monitoring group had higher quality-adjusted life years and lower costs. The variables with the greatest potential to impact cost effectiveness over an 18-month horizon were diagnostic performance measures for fecal calprotectin and remission rates for biologics. At 1 year, biomarker-based monitoring strategy was more cost-effective regardless of whether therapeutic drug monitoring or optimization was performed. Once patients with active Crohn's disease have achieved symptomatic and biomarker remission after a close follow-up, then an ileocolonoscopy should be performed to confirm endoscopic remission. This hybrid biomarker endoscopy monitoring approach was less costly than the endoscopy-based monitoring approach only, and it was associated with an on average higher quality-adjusted life years. Monitoring disease remission in Crohn's disease with endoscopy is not without risks or costs, and consideration must be given as to whether monitoring exclusively with endoscopy represents the most ideal strategy for treat-to-target monitoring in Crohn's disease. The short-term cost-effectiveness of biomarker-based monitoring over 1 year in this microsimulation model is seen because the long-term effects of achieving endoscopic remission are yet to be realized, and this is why the endoscopy-based monitoring strategy becomes progressively more cost-effective over time. The strengths of this study include having a microsimulation modeling which allows modification of probabilities and outcomes based on individual simulated course, taking multiple patient and disease course variables into account. Use of multiple patient and population level inputs to guide model estimates was another strength of the study. The limitations include that the authors assumed full adherence to endoscopy-based monitoring throughout the entirety of the monitoring period. The definition for endoscopic remission across studies and literature is variable. Authors were not able to account for varying accuracy of calprotectin. Authors were not able to incorporate safety or adverse events into the cost-effectiveness model. These results are not applicable to patients with isolated small bowel Crohn's disease, particularly when beyond the reach of traditional ileocolonoscopy. Analyses were performed with a healthcare payer perspective and did not model alternative perspectives. The take-home points include that at a 5-year horizon, endoscopy-based monitoring is more cost-effective than biomarker-based monitoring. At shorter time horizons or when evaluating patients already in endoscopic remission, the biomarker-based monitoring strategy becomes progressively more cost-effective. The ideal monitoring approach to a Crohn's disease patient starting biologic therapy is a hybrid biomarker and endoscopy-based approach to optimize cost effectiveness.